So we're here to start to try to synthesize a few ideas. So some of the ideas that we're going to be talking about are implicit versus explicit learning, or implicit and explicit learning, not necessarily in opposition. Speaking about the concept of relational motion and patient positioning and how these things all start to play with one another. The example that I'm going to use here is the hip, and specifically internal rotation or medial rotation, whichever term you prefer, of the hip. And you may prefer internal or medial rotation of the thigh with respect to the pelvis. So if we say the thigh with respect to the pelvis, then maybe we have a slightly better conceptual idea. Lots of words to talk about the same thing. So the patient's in prone, and we're going to use this leg. Okay? Internal rotation in this context is moving this way. Now, depending on how you frame this in your mind, you can think about the foot with the knee bent at 90 degrees and the foot moving away from the individual. If this is where your intention is, or if this is where your attention is, and you're thinking about the foot, you've got an analog, or essentially a proxy for the actual motion that you're creating. The motion that you're creating, or the area of attention, really is the hip, or the head of the femur in relation to the acetabulum of the pelvis. So the actual motion is happening somewhere around here. Here, the thigh is rolling away from the midline on the back, and on the front it's rolling towards the midline. So you see, all of these things can be very confusing. Depending on where my attention is, I may be thinking a very different thing. Now, the proxy, the most clear proxy, the most clear analog is actually the foot. So if I think about the foot moving away when the knee is bent at 90 degrees from the midline, then I've got something to consider here. Now, the implicit deal is if I'm thinking about internal rotation of the hip, internal rotation of the thigh with respect to the pelvis, then implicitly, if I try to recreate this in the same position without the knee bent, then I would start to have to do this, okay? I'd start to have to play around and try to create motion of the thigh in the direction that I want. The foot is not going to act as the same analog anymore because the knee's in a different position. What ends up happening is I would have to roll the thigh towards me, okay? That is the analog. It's not perfect because the patient's thigh is in contact with the table. So if somebody teaches me to look here, perfect, no problem, I can figure it out really quickly. If the context is changed, the implicit learning process, so implicit learning processes tend to be rigid, slow, and automatic, right? So I figure it out over time because I'm consistently messing up, but they're rigid and slow. So I would be looking to take the heel and move it out here. It's not going to work in this situation. This is where explicit learning comes in. Somebody needs to give me a new strategy, or this would all be faster if they gave me a new strategy. So if I said the thigh, the posterior aspect of the thigh rolls away from the other leg, then we can create that. We're going to have you on your back. Okay. So now, in many situations where somebody's trying to get you to learn a concept or learn a principle or be able to repeat things in different positions. Okay, so we went from prone to supine. So we're talking about the concept of a patient being in a different position and attempting to create the same movement, because some people will know that some patients are unable to be in all positions. They may be able to be in a few positions with respect to the table, or one. So I should ideally, as a practitioner, be capable of creating the same motion in each patient position. Now, the most common way to create internal or external rotation of the hip or of the thigh in relation to the pelvis is in this position. Now, I've got the knee bent, right, but I also have the hip bent. So this is not the same as in prone because I've introduced hip flexion. If I just wanted to introduce knee flexion, right, so that I can keep in mind what I want to do with the patient's heel, if that's my primary strategy, using the foot as my proxy or my analog or my point of attention, I have a problem because I can't bend their knee. Now I could shimmy him over, bend his knee, and then kind of crank him out so that the knee goes in towards, so the front of the thigh goes towards the other thigh while the back of the thigh comes away, right? Or this is where the implicit process comes in. I'm thinking, and then I start to say, okay, well, I want the back of the thigh. So it's hard to see the back of the thigh, so it's not the best point of reference. It is easy to see the front of the thigh, so this is where I could think and try to spin myself around. I might go a little crazy. Or somebody could explicitly say, when the patient's in prone, you want the thigh to move away from the midline or away from the other thigh. But in supine, because I'm looking at the other side of the coin, I want to create a roll of the knee or a roll of the thigh towards the other thigh. It's the same net result as far as motion is concerned, but we have the implicit process, which would take me a long time and be very rigid. It's automatic. Or we have the explicit process, which tends to be quite flexible and can be very useful in the early stages of learning. But the issue that I have is in a different position, the patient is capable of doing different things, or really the table gets in the way of the capacity to do different things. What ends up being very important is feedback from an instructor, such that if I'm trying to provide the opportunity to figure this out on your own, when you're having a hard time, I can give you useful feedback when it's required. If you don't want it, if you haven't asked for it, it may not be as useful. When you ask for it, it's very useful. If you can figure it out on your own really fast, then that's an even better thing. But it's been relatively consistent that people can't always figure something out. There may be some form of block in the way that they're thinking. So we've talked about the fact that I can create internal external rotation of the hip or of the thigh in this position where I've created hip flexion, but I also have knee flexion, so it's a little bit easier to understand. I can create it here. I can roll the thigh or the whole leg. The net result at the hip is getting our internal external rotation. Really, our internal rotation is what we want to talk about. Now, if I put the patient in lateral, so I'm going to have you on your side facing towards the camera. There you go. I'm talking about my patient positioning. I'm going to work from behind the patient. So what I want is actually to slide your shoulders back towards me. There you go. So now I have the patient closer to me. So we're talking about the concept of less table means I need to make the patient more stable. The space between us is unstable, right? So I bridge towards the patient. I make the patient come towards me, so I don't want to lean in all the way. Now I have two options here. This, if I leave the patient in this position with the knees bent, I have relative hip flexion and knee flexion. So internal rotation, if I'm thinking about the foot, I can move the foot away from the middle of the patient on the posterior surface, and all of a sudden I have my internal rotation of the thigh or of the hip. Is this perfect? Not absolutely. Okay, this is one way to do it. This would be the analog to the patient being in supine and creating internal rotation with hip flexion. Now, I can get rid of that hip flexion, okay? I can come more, now all of a sudden, with the leg straight, this becomes the analog to the prone position, and I can simply lift the foot away. So the back of the thigh, so now because I'm in a different position, I have a different visual, I can see the back of the thigh moving away from the other thigh. As far as being in supine is concerned, I can see the front of the thigh moving towards the other thigh. I also have my other visual where the knee is in relative flexion and I have the foot coming away from the midline on the posterior surface. So that's my internal rotation. And there's a lot of words going on here, but what we really want to try to focus on is the visuals. If I see hip flexion, right, that's my analog to be the easiest way in supine, right? Or it's my analog to a patient with their knees bent in lateral. So I can start to chunk these things together. When I have hip flexion, I can start to usually have knee flexion as well and start to move the foot in relation to the patient or in relation to the patient's midline. If I take this patient and I put them in a seated position, so we're going to have you sit up. Yep, facing that way. Okay. And what we can do here, now, the patient is in a seated position which automatically creates hip flexion. So if it automatically creates hip flexion, we are now in an analog to the supine position where I've created hip flexion based on gravity, based on the way the patient's sitting, based on the table. We also have knee flexion. So the easiest thing for me to do here, you won't be able to see the patient's foot because of the camera angle, but I can pull the patient's foot towards me and I've created my relative internal rotation again. I can't use the concepts that I would use, or the same reference points as I would use in prone, because the patient is in a seated position. So I can use the reference points that I would use in supine rather, or say maybe in lateral with the knees bent or with the hips bent because I have my hip flexion. So what I'm hoping to give you here is some explicit visual description, some explicit verbal description of placing the patient in different positions to create the same motion. We will likely repeat this with other motions, but the big deal is you have to look at the concept of relational motion as well. So in supine, the easy relational motion is hip flexion and knee flexion to then get into internal external rotation, but obviously we're talking more about internal rotation as a consistent point. Knee flexion alone is my analog to prone. Right? I can perform it in lateral as well, but I cannot perform it particularly well or really without great difficulty in supine, and I definitely can't really create it in a seated position. The hip flexion I can create in seated, in lateral, and in supine, so I just have to start to flip my reference points around. But the fact that I have a traveling reference point becomes challenging without practice or without explicit teaching. So we want to talk about, again, just briefly touch back on implicit learning. It tends to be automatic, rigid, and slow, where explicit learning tends to be fast and flexible. So we want to provide opportunity for implicit learning, but also utilize explicit teaching, explicit feedback when useful and necessary. So we look and give you the explicit examples of varying positions with the same movement and talk about how some positions are similar and some positions are different. Lateral, I can have my analogs to the prone position with just knee flexion, right? Lateral, I can have my analog to the supine position with hip and knee flexion. As far as creating internal rotation, in supine, I have hip and knee flexion, or I have a completely straight leg. And then in seated, really it acts more like supine. The one benefit that I have, should I actually be trying to put a little bit more torque on this hip, is that I can start to use a patient active approach. So I can create internal rotation of the patient's thigh, and then I can have the patient, I want you to twist that way, as I can start to put some torque from the body, so I move the torso in relation to the hip now. I can start to add things in like this, and just sit like it. So again, depending on the position, you want to create a situation where you're practicing, trying to be creative on your own, which engages implicit learning. Find your analogs from one position to the other, and try to identify a steady signal. So whether with internal rotation of the hip, it could be knee flexion, hip flexion, or both combined, which will allow you to start to think about this one movement in different positions and how to achieve it should you be required to.